pharmacological options and for the treatment of systemic hypertension. And it's going to be over 2 lectures. The first thing that you have to wonder is whether this treatment and this trouble dealing with hypertension is the question, is it worth it? Is it worth it to treat systemic hypertension? And I heard Dr. Skaina referring to this point in particular, which is the fact that some of the new results from the new studies after 2000, we found that there is a reduction in stroke mortality rates right after the introduction of the treatment of systemic hypertension. And it was a very significant reduction in these mortality rates. Another thing was also the reduction in the congestive heart rate, congestive heart failure mortalities, and even morbidities just after the issuance of the treatment of systemic hypertension. So overall, when you look at such killers, stroke and congestive heart failure, it is worth it to try your best to treat systemic hypertension. But how do you treat it? What are the approaches to treat systemic hypertension? And let's forget about one of the major factors, which is the lifestyle changes, right? And she just talked to you about that, including exercise, cessation of smoking, alcohol drinking, and changing your food into something called the DASH food types, which include vegetables and more fibers and so on. All of these modifications are necessary to be started in any patient having systemic hypertension. And we found that there's at least a reduction of 15 millimeter mercury in the systolic blood pressure just right after the lifestyle modifications. So it is worth it. Now, the other thing, which is my job, is the pharmacology and the treatment, the pharmacological options in the treatment of hypertension. And as always, I like to give you principles that you might apply to understand how we got into these treatment options. So, let's start first with the target blood pressure. What do you think is the target blood pressure after the treatment? كيف بتعرف السيستميك hypertension؟ More than 9. So the first target is to treat the systolic to below 140 and the diastolic to below 90 millimeter mercury. Now this is good, but the problem is that most of these patients have comorbid diseases, like what? Diabetes, hyperlipidemias, and so on. So in such conditions, the target is even below that, at a lower level. And they said that exactly. Life always seeks balance, equilibrium. And your body is not short-willed or without any powers. If you try to modify one component of the equation, it will try to compensate by the other components. Okay? So our life is not that easy. If you try to reduce the cardiac output, one of the compensatory mechanisms of the body is to induce or increase peripheral vascular resistance. Okay? So maybe the best choice is to try to have a comprehensive reduction of all of these components. Now, what's the easiest way to reduce all of these components? Could you find a drug that could target everything? Mostly not, or unlikely, let's say. So what's the other choice? Exactly. And this is actually what happens in life. We start the patients on the monotherapy according to the staging of the disease, but almost 2/3 of hypertensive patients will need a combination therapy at one point of their lives. And this is a statistics, and it's proven. Okay? And you could understand now and relate to this principle. Things are compensated in your body, so you try to combine drugs to target multiple components of the equation, and that will lead to comprehensive reduction of blood pressure. Let's start with the cardiac output. What do you know about cardiac output? How is it regulated? And I'll give you something that you will remember forever, which is to have a metaphor, an analogy. Okay? Let's imagine your heart as this pump. Now, for this pump to function, a water pump, what do you need to couple it to? The first thing is to a tank, and then to have pipes, and then it will get to the faucet, and then you will get water. And that's your cardiac output. So if you want to manage this and control this, you have to control what? The components. The first thing is what? The power horse of this, or the horsepower of this pump, right? Which is what? The heart what? Contractility, conduction, velocity, and so on. What else should you control also? Now, let's forget about venous system, about this. Let's say the volume, okay, that will go back and supply this machine or pump, okay, which is the blood volume, and it's reflected by the venous return to the heart. Now, the other thing which is important is what? Is this pipe and its patency, which is reflected by resistance. And another thing which is important is what? It's the faucet, the rate. How much do you open the faucet, right? And that's why the major controllers of cardiac output are the heart rate, contractility of the heart, and including also the conduction velocity, the blood volume, and the venous return, in addition to the patency and the peripheral vascular resistance. So if we want to reduce cardiac output, what should I do? According to the regulators. The first thing is to try to reduce the heart rate, decrease the contractility, decrease the conduction velocity of the heart. Give me one class of drugs that could produce all of these things. Exactly. What kind of beta blockers in particular? The selective beta-1 blockers. Could we give, or do we have another class that could target all of these or most of these? Exactly. The calcium channel blockers. Okay? So both of these classes are used in the treatment of hypertension mainly because they will affect all these components that regulate cardiac output. The other factor which we talked about is what? Is the blood volume. Okay? And how do I reduce blood volume? Take blood from the patient.
Renal excretion.
Okay, so your colleague is saying diuretics. Okay, which means what? Let's take it as a concept, as a principle. If you want to reduce the blood, I need what? What's the major regulator of the contraction? Exactly, calcium. So I need calcium to get into the cell. Okay? Now, how do I regulate the calcium influx? Mostly it's the autonomic nervous system. So I have, for this to happen, for the contraction to take place, I have the alpha-1 receptors, okay, autonomic, sympathetic. Once these are activated, calcium influx is increased, contractility is what is induced, okay? On the other hand, there is a balancing factor, which is the presence of another type of autonomic sympathetic nervous system receptors, which are the beta-2 receptors. Once these are activated, it will induce certain negative inhibition of both the calcium influx and also the actin-myosin cross or sliding and cross reactivity. Okay, and that's what leads to relaxation of the vascular smooth muscle itself. Once you induce relaxation, what's going to happen as a phenotype of the vessel? Vasodilation. Once you induce the alpha-1, there is vasoconstriction. But the problem is that what? Both of these are sympathetic receptors. Okay? So most of these will be affected by epinephrine and norepinephrine, maybe to the same degree, maybe not. But let's say in principle they will be affected to the same degree. If I have epinephrine, it's going to bind to both. So what's the net? Should be zero. Not really. So this is something important. Under resting conditions, okay, the vessel has something called vascular sympathetic tone. Okay? So your vessel does not collapse at any point. So that's why efficacy and maybe frequency and strength of the signaling through alpha-1 at resting conditions exceeds the signaling through the beta-2. And that's why you have your tone within the vessel. So what is the major class of drugs that could be used to reduce peripheral vascular resistance? Alpha-1 blockers, right? Should they be stronger than the beta-2 agonists, for example? Yes, as I said, because under these resting conditions and even in pathological conditions, this is going to be exaggerated even more. So one of the major classes to reduce peripheral vascular resistance is to give alpha-1 antagonists. So for the peripheral vascular resistance to be reduced, just take it as a principle. I want to increase the vasodilators. I want to decrease the vasoconstrictors. Starting with reducing or the vasodilators. One of the major classes is the alpha blockers. Give me another class that could be functioning as beta-2 agonists, but it's not that efficient in clinical practice, so let's forget about it. Another thing which is important, calcium channel blockers. Again, we said the major regulator or inducer of the contraction is calcium influx. So calcium channel blockers will be effective. What else? What else of regulators or vasoconstrictors you have within your body? What do you know? Nitric oxide is good, but it's bad because it's non-specific. That's a major problem. But something you have to know from the physiology lectures. What is a very potent vasoconstrictor within your body? Exactly. Angiotensin 2. So something to target this whole pathway of the renin, angiotensin, aldosterone will be a very powerful class to reduce the peripheral vascular resistance as a net result. Okay? So the decrease in vasoconstrictors include the renin, angiotensin, aldosterone system antagonists or inhibitors. On the other hand, I'm going to explain tomorrow one particular class which is interesting, which are drugs that are direct vasodilators. They have a funny and nice mechanism you will learn tomorrow. طيب, زي ما حكينا, most of the patients will get into combination therapy at one stage, and it was estimated to be 2/3 of your patients. Plus, again, the lifestyle modification. طيب, let's start with the first class. And I'm going to try to organize the classes according to their clinical application. So something I will mention today, the first class of drugs will be actually the first to be used in clinical practice. This is your first line in the treatment of hypertension. And that is actually the diuretics. What do I mean by the word diuretics? It's the increased urine production. How can you increase urine production? خليه يشرب مي أكثر. ولا فهمت شيء. حد احكي. قلل الري absorption of what?
Sodium.
الواتر يعني؟
Sodium.
Can I reduce the reabsorption of water? طيب كلهم بيحكوا sodium, which is actually true. Always remember that if this is water, this is sodium, and they are soulmates. Wherever sodium goes, water flows. I cannot regulate at a very efficient way, clinically, the reabsorption of water. Although we have certain channels for water, particularly within the collecting duct, and these are under the control of what hormone? The antidiuretic hormone, okay? But regulation of that is very hard. So what we found is that the best mechanism is using this kind of illegal relationship between sodium and water. They are truly solvents. Wherever sodium goes, water flows. So if I want to induce diuresis, I should do something called natriuresis, which is increased sodium excretion through urine. You got it? Now, how do you do that? Now, unfortunately, the effect, where should the effect be? These drugs should target what organ? Great, the kidney. Okay? So our target is the kidney and the nephron, several parts of the nephron. Now, I don't know if you studied that in physiology or not, but most of the reabsorption of sodium is something passive. It's about 65%. When you have a passive process, it's very hard to target it pharmacologically. Okay? This is why it's unfortunate for us. We cannot target this big portion of the sodium reabsorption. So what we are left with is what? The 35%. And this happens at several stages within the nephron and several parts. The first part is the distal convoluting or convoluted tubule. You know these names? Okay. Have a part. Okay. We have one type of a co-transporter within that part, which leads to the reabsorption of sodium and chloride at the same time. Okay. This is urine here, and this is blood. So this is shunted from the urine back into the blood. Okay? So if I want to reduce the reabsorption, what should I do? I can block this kind of co-transporter. And we have one type and one class of the diuretics that target this co-transporter, and these are called the thiazide diuretics. Now you will have a separate lecture about diuretics next year for more details, but just get the concept. Now, what is the percentage of reabsorption at this place, if you remember? You don't remember, of course. It's actually 5%. Okay? So by giving this class of drugs, I'm reducing the sodium reabsorption by 5%, and that's going to increase the water excretion by 5%, which is significant or non-significant? هي شوي يعني borderline ماشي الحال. هذا الموجود. Okay? But يعني it's very commonly used, and we will say why in a minute. Okay. Now the second class this is an example, which is the most commonly used thiazide diuretic. You don't need to remember names now. It's hydrochlorothiazide. But if you have a hypertensive patient or parent or relative at your house, you will see that most of them use this drug, Modrex. Now, the second class of diuretics are drugs that will target another kind of co-transporter that's present at a separate place, which is the thick ascending limb of the loop of Henle. Okay? And there we have another kind of co-transporter. It's a transporter that transports sodium, 2 chlorides, and potassium from the urine back into the blood. If I block that, I'm going to lead to what? To natriuresis and diuresis. Now, these are called the loop diuretics, which is easy to remember because they target the thick ascending limb of the loop of Henle. Right? Thiazides are called thiazides because their structure contains something related to the thiazide thing. Now, what is the percentage of sodium reabsorption that takes place here? It's actually 25%, which is significantly higher than that used or induced by using the thiazide diuretics. But you will see that we will use this less than or less frequently than the thiazides. But that's a good point. Now, the most commonly and frequently encountered example of a loop diuretic is a drug you should also know, which is furosemide or something called Lasix. Okay? I guess you heard of this term. Lasix. And as you can see, with the furosemide and the loop diuretics, we have both routes of entry, the oral and the IV or injectable route for loop diuretics, which was not available with thiazide diuretics. Right. Let's start with, so what? So you reduce the blood volume. How do you reduce the blood pressure? يعني شو الميكانيزم? So let's start. And the diuretics will affect the kidney. They will induce sodium and water excretion, and that will reduce the blood volume. Okay. So the basic effect is what? Is to reduce the venous return and cardiac output. Okay. So by reducing the blood volume, and this is the part I was talking about, adding that to the equation, which is the central venous pressure. When you reduce the amount of blood within your body, that's going to reduce the central venous pressure. So by that, you will reduce blood pressure directly, and indirectly, after a while, you're going to reduce the preload and cardiac output, and that will lead to reduction in blood pressure. Okay? So we might have an acute effect, which is related to the direct reduction in blood volume and central venous pressure, and over time, you're going to lead to reduction in cardiac output. Why am I saying over time? Because again, let's go back to the principle. The heart will not accept just, okay, the venous return is reduced. It will have a compensatory mechanism to compensate for this reduction in venous return, which is what? Increasing the heart rate and increasing what? The contractility and conduction within the heart. Okay? So this is compensating. So it will take a time. And if it doesn't take place, what should I do? زيتنا الدوسج الهارت حكى لك the heart is stubborn. شو الدواء الثاني? Exactly. That's the point I'm talking about. If it doesn't work after a while, you're not getting what you want, which is the comprehensive reduction of cardiac output and preload. Just try to combine it with another class of drugs that will target the compensatory mechanisms, which is what? The sympathetic overactivity, heart rate and contractility and conduction velocity. So I will give a beta blocker in addition to the diuretic. You got it? Nice. طيب. Practical comments which are important. This is important. This is the drug that we always seek. It's generally safe. It's actually safe. It's inexpensive. Less than 5 JDs. Use their terminals. And effective. It is actually effective. Okay? In the treatment of systemic hypertension, at least for a while. Okay? So that's why you should consider that as your first line antihypertensive drug. Okay? Now the other thing, which I touched on several times now, diuretics function because it's safe, inexpensive, and effective. It's your first line. And the other thing, because of the compensatory mechanisms, it is integral to the combination therapy of hypertension. It's not uncommon to find a patient having a diuretic plus another class of drugs. This class of drugs should target what?
The heart.
The compensatory mechanisms. Okay? Like the sympathetic overactivation. Give me another class that could be also used effectively with. Calcium channel blockers could be used, but more importantly, what's a major compensatory mechanism within your body for the regulation of blood pressure? The renin-angiotensin-aldosterone system. Okay? So it's not uncommon to find a patient having both a diuretic plus a beta blocker, or a diuretic plus a renin-angiotensin-aldosterone receptor antagonist, system antagonist. Okay? But further practical comments. It's important to know that thiazides are usually the first thing to start with. Give me one reason. Why should I prefer thiazides over loop diuretics? If you remember, thiazides will reduce the reabsorption by only 5%, while that will reduce it by 25%. Why should I always think about this? في واحد بتحكي معه. أنا مستعد. We will mention in a minute that both of them will induce hypokalemia. But something important as a physician. ممكن. Okay. هلا بنحكي عنها, which is an important point. Another thing. مش قوي. More important. What's the most important subject in your clinic? Exactly. It's the compliance to the drug. Imagine that you are reducing or inducing a diuresis by 25% for your patient every day. Okay? Particularly if you want to give a late night dose. Okay? That's very hard. You should take care of the emotions and feasibility of giving a drug to a patient. So it's always more preferable to start with something moderate, like the thiazides, which will induce a 5% reduction, which could be managed by a patient. He's not going to go, or she's not going to go to the bathroom that frequently. Okay? Manageable. Now, the other thing, which your colleague mentioned also, is that if you are reducing or inducing a diuresis by 5% compared to 25%, which one will have more compensatory mechanisms? It's the 25%. So the percentage of the need for combination therapy with loop diuretics is even higher. Now, because of, let's say, thiazides are first-line antihypertensives, particularly in the elderly patients. Okay? And I'm going to touch on that in a little bit, why it's preferred in the elderly. But just take it from the point that this is effective, safe, and inexpensive, and it will not have poor compliance. Now, one thing which is important about loop diuretics is that I mentioned it's given as an injectable formula, okay? And because it induces a large percentage of diuresis, we prefer to use loop diuretics for cases associated with fluid overload. Like, I'm not gonna, or I don't want to give my patient home-based treatment of loop diuretics, okay? Unless I need to, like my mother, okay? There's nothing that is working for her. At one point, you have to induce such large percentage of diuresis. But in principle, for most patients, I wouldn't like to give them loop diuretics too much or too frequently home-based. So we prefer to use it in cases associated with fluid overload, particularly if we are dealing with the patient at the hospital. Okay? Give me a case of fluid overload state. ماشي. There's something more common. Exactly. Congestive heart failure is something very important, particularly because it will lead to lower limb edema, it might lead to pulmonary edema, and so on. Another thing which is renal failure, okay? In these conditions, I might need to use loop diuretics, and particularly at the ER or at the hospital by the injectable forms. Type. Yes. Again, fluid overload, why am I preferring loop diuretics? Because of the percentage which is high, 25%. The second thing is that it can be given as an injectable formula, okay? So it might induce the effect at much faster rates. With thiazide diuretics, it's not going to be that effective, at least at the hospital. But if I want to discharge my patient on a drug, I might use thiazide diuretics. Yes. It's a good point. We can do this in there. But in principle, thiazide diuretics will lose their efficacy if we have a renal impairment. Okay? While loop diuretics might still have an effect, and we might even increase the dose to produce the effect. The thing is, we have something called the high ceiling and ceiling effects of these classes. Thiazide diuretics are ceiling drugs. Whatever you go up with the dose, there's no point. There's no increased efficacy, and what you are inducing is an increased percentage of side effects. With loop diuretics, we have a high ceiling potential. Like you could increase the efficacy of the drug by increasing the dose. And that's why it could be given in renal impairment with some sort of efficacy. Now, side effects. The basic thing to know is if I'm treating a hypertension or if I'm targeting hypertension, what's the first side effect to consider? Hypertension. So this is a given. An antihypertensive drug, the first side effect is hypotension. This is one. What else could be related to the function, for example, of thiazide diuretics, which you mentioned earlier? Hypokalemia, exactly. Right? Sorry, Mr. Thiazide, the loop diuretics, okay? Because they will affect a co-transporter that has the potassium within their function. But if I said that thiazide diuretics also induced hyperkalemia, could you explain that? Now we will go over these things later on in more details, but just for your interest. انسى الكلورايد خلينا على الصوديوم. I worked on in that co-transporter. I stopped the reabsorption of sodium and potassium. Sorry, of sodium and chloride. ماشي? So when sodium will reach the final stages of the nephron, it's going to be what? Too much or too concentrated within the filter, right? We have another type of receptors, another system for the reabsorption that takes place at the later parts of the distal convoluted tubule and even within the collecting duct. And that system will act to increase the excretion of both sodium and potassium. If I'm giving too much sodium, this system will going to be active much more. And that's why, as a compensation, I will lose even potassium. شايف في hypokalemia يحكي. أنا مخليها للسنة الثالثة بس. تعالوا مش راح نوثق منكم سنة لحد ما ليش مستعجلين؟ تلكم مش نصيحة. طيب طيب this is the point. And the loop diuretics, it's easy to understand, but why with thiazide diuretics? Why does it happen? This is the system. This is the nephron. I'm targeting the distal convoluting or convoluted tubule, and I'm blocking that co-transporter. What's going to happen? The major result is to increase the percentage or the concentration of sodium within the filtrate. Okay? Now, once it reaches the distal parts of the tubule and even the collecting duct, okay, we will have more sodium, right? Now, at these distal parts, we have a system that we're going to mention in a minute that will have the functionality of both sodium and potassium exchange. So if I'm giving too much sodium, what's going to happen to this system? It's going to be activated even more, and that's going to lead to more and more excretion of potassium into the urine. ماشي؟ ما فهمتوش طبعا صح؟ استرجع. طيب. إذا حكينا hypokalemia, حكينا hypotension. These are the major things to think about. Okay? Now the other thing which you might think about is something called hyperuricemia. And we have several mechanisms for that. But I just want you to remember one thing. One mechanism, which is easy to understand. When I say hyperuricemia, I might not be increasing the amount of uric acid within your blood. I'm increasing the concentration. How am I doing that? Exactly. By losing this solvent, the volume of this solvent is reduced, okay? Although the amount of the solute is maintained, so the final concentration is increase. This is called volume contraction because of the effect of diuretics. Now, this is important where or when? Only when you deal with a patient who has a disease related to hyperuricemia or risk factors for hyperuricemic diseases, like what? Like gout, okay? So take care of that when you are giving diuretics. Now, something in particular important, and it's good for the exams, okay? We have no idea why does that happen. It's that loop diuretics have an effect on, or a toxic effect on hearing, and it leads to ototoxicity. The mechanism is totally unknown, but is it found? Is it noticed in practice? Yes. And when does it happen more frequently? Give me one. Exactly. When you combine it with another ototoxic drug like aminoglycosides. Right. Now, finally, a final class of diuretics which is not that particularly useful as a monotherapy, but we might need it, is a drug that will try to reduce the loss of potassium, okay? Because it's going to act on another kind of transporter that will transmit or reabsorb sodium while losing both hydrogen and potassium. If I block that, what's going to happen? I'm going to increase the sodium loss while keeping both potassium and hydrogen, right? So that's why these are called potassium-sparing diuretics. What is the percentage of diuresis induced by that? It's only 2%. Is it that significant? No. When do you like to use it then? ليش عم بحكي عنه؟ And why? Exactly. If I want to give a loop diuretic, I want to increase the dose. I'm too afraid of hypokalemia as a side effect. I might combine it with a potassium-sparing diuretic just to what? Keep the potassium level controlled. Let's say that. But what's the side effect that you will worry about then?
Hyperkalemia.
Hyperkalemia. Another thing is انسى بلاش أهم من هيك. No.
Tachycardia.
Hypotension. Okay? The combination of these two drugs might give you two important side effects, hyperkalemia and hypertension. But don't forget, can I use it alone in the treatment of hypertension? No, it's crap. It's only 2% reduction. But I can use it only as a combination with another class of drugs that will induce hypertension. طيب. لسه مطولين طيب. The final class I'm gonna cover, or at least touch base on today, is the adrenergic blockers. And notice I did not specify what type of adrenergic blockers, because we have several types that could target hypertension. Give me some classes. I have the alpha blockers, which will have an effect on the vessel, so they will induce a reduction in peripheral vascular resistance. I have another type, which are the beta blockers, particularly if they are cardioselective, most of the effect will be on the heart. Can I get both of these effects together at the same time? No. I mean, in the adrenergic blocker category. No, I can't. My kid. How? How can you? What? لا يعني الفنفرين أصلا will stimulate. How can I inhibit all of this at the same time? احكي اللي براحتك. من وين؟ بالابدومين؟ سمباثيك كله هذا من وين نعمل له انهبيشن؟ من وين بيجي؟ من الصريح؟ بيجي من البرين. So go to the major source, which is what? Which is the central sympathetic centers, or centers, let's call them, okay, located within your brain. Go there and inhibit the whole flow of sympathetic signal. And you will induce both of these effects at the same time. طيب. Let's start with alpha-adrenergic blockers. One idea is to inhibit the alpha-1 receptors within the vascular smooth muscle cells. That's going to induce what? Vasodilation. Okay? But if you induce vasodilation, how is that going to affect the equation we talked about? Reduce the peripheral vascular resistance, and that's going to reduce the blood pressure. What's the compensatory mechanism you're going to be afraid of? Increasing the cardiac stimulation, increasing the heart rate, the conduction velocity, and so on. So give me symptoms. How might the patient feel after giving him an alpha blocker? Tachycardic, okay, and palpitations, of course. And what else? Flushing. Okay, that's good. Match. Now, we have one drug which is used in hypertension. It's prazosin. It's used only in mild to moderate hypertension. Just keep this in mind. It's rare to find a patient using an alpha blocker. Okay? And if I want to use it, I have to use it with what? With a beta blocker. That's a given. Okay? Because of the frequency of side effects. It's seldom used alone. The combination with beta blockers is very commonly faced in clinical practice. The side effects I'm afraid of are two, which are what? The most important thing is an antihypertensive, hypertension, hypertonia. خلاص antihypertensive hypertension على طول لازم تكون. Plus that you are afraid of the cardiac stimulation and tachycardia, and that's why you are giving the beta blocker. Just one piece of information, and I mentioned several times before. What's the meaning of orthostatic hypotension? Postural, okay, ماشي. هلا زي ما حكينا. Your vessels under resting conditions have the alpha-1 receptors acting more. Okay? You have some sort of a tone, right? This kind of tone will keep the vessel at least patent a little bit and keep blood flow through that. Now, if I come all of a sudden, at the first dose, give a drug that will block these receptors, what's going to happen? You're going to lose the tone. Okay? That's why hypotension at first dose is a very commonly frequent or encountered side effect of alpha blockers. You are taking out the vascular tone. Particularly if you combine it with what? With standing up all of a sudden. Okay? And the gravitational pulling of blood. There is no tone, and the gravity will pull the blood down, so the patient will be what? Dizzy. So the first dose should be given what? At bedtime, okay, at night, and the patient is sitting on his bed, or her bed. Okay? Take care of that because it's commonly encountered. What else can I do to reduce the frequency of this side effect? Start with a low dose and start building up. Okay? So the patient will get used to this loss of the vascular sympathetic tone. ضايل معنا 5 minutes نحكي عن البيتا adrenergic blockers, which is not that long again. Mostly what we use are the beta-1 blockers, the selective beta-1 blockers. What are they going to induce? Just take it for granted. Forget about the name I'm going to mention now. It's going to inhibit the whole heart. The heart as a globe. Every function in the heart will be inhibited. Contractility, heart rate, conduction velocity, and so on. And even the relaxation power or efficiency. And that's why the major effect of beta blockers will be on what? On cardiac. And that's going to reduce the blood pressure. Now, something you have to take good notice of is that the sympathetic system is always like sodium and water. It has a twin within the body. And that twin system is the renin, angiotensin, aldosterone system. Once the sympathetic system is activated, renin, angiotensin, aldosterone system is activated, and vice versa. And if I block the beta receptors, one result will be what? To block also the renin, angiotensin, aldosterone activation. And this is something very integral to the functionality of beta blockers. At the long run, they're going to decrease the production of renin from the juxtaglomerular cells, That will inhibit the renin-angiotensin-aldosterone system, and that will reduce the peripheral vascular resistance. And that will add to the reduction in blood pressure. What better drug could you ask for? I am targeting both parts of the equation, peripheral vascular resistance and cardiac output. I'm not that afraid of compensatory mechanisms by giving the beta blocker. You got it? Type. We have the cardioselective, and there is a new class of drugs which is great, and it's taking momentum in the States. It was a combined alpha-1, beta-1 blocker. Okay? So that's comprehensively reducing peripheral vascular resistance and the cardiac stimulation. Now, something I want you to know is that these are first-line drugs, particularly in patients who have concomitant heart disease. Because in principle, if I'm giving the beta blocker, what am I doing to the heart? And I'm بدلله. I'm resting the heart. Okay? So if you have a patient who has some sort of inefficiency, let's say, of the heart, you might think about beta blocker in the treatment of hypertension. Particularly in young patients. This is important because young patients always have a higher sympathetic drive. Okay? So their hypertension might be mostly controlled by sympathetic blockers and beta-1 in particular. This is important, and we mentioned in our lectures of the respiratory system, selectivity is lost with high doses. Okay? So I should take care when I give a beta-1 blocker to an asthmatic patient. Okay? Although it's cardioselective, but I'm afraid that selectivity is lost at high doses. I might induce bronchospasm. Right? Acute treatment is not that effective, and this is particularly important because most of the effect, we want the comprehensive reduction of both the cardiac output and the peripheral vascular resistance. It does not happen all of a sudden. You need to build up. Okay? And I'm going to mention something later on about the rule in clinical practice. One thing you have to know, and this is nice and I want to leave you with. If I am having the cardiomyocyte, the cardiac cell, and there is the beta-1 receptor, right? It gets its stimulation from the sympathetic center, right? That's going to induce what? That's going to induce contraction, right? This is the normal functionality. What if I come here and block this beta-1 receptor? Would the heart like it? No, of course not. Because I said the major function is brought by the beta-1. You stop it, all of a sudden you're inhibiting the heart as a whole. The heart is stubborn, will not like it. It wants to compensate. Everything in your body wants to compensate. That's why we suck as physicians. Whatever you try to do, your body will try to compensate for that. So if I block this, how does the heart respond? How does it compensate? The first thing exactly is increasing the number of receptors. Okay, you're giving me one molecule of a beta blocker. I'm going to increase the number of receptors, and you cannot block me anymore. This is receptor uptake. What else could the body do? Yes? No, the body, how does it compensate? No. Yes, exactly. The other compensatory mechanism is the sympathetic overflow, sympathetic overactivation, too much signal coming down from the brain. That, good. Why is that important for you as a physician? Why? Why? Okay, this is very important. You cannot stop the drug all of a sudden, abruptly. You have to stop the drug gradually. Because if I stop the drug all of a sudden, okay, and I'm leaving the patient with the type of receptors he has, the number of receptors, and with this high signal of coming from the center, what's going to happen to the patient? The first thing is rebound hypertension. What I did over the years, I'm going to just damage within seconds. What else? I'm going to over-exhaust and overwork the heart itself. So imagine a patient who has a coronary artery disease and I'm overworking his heart. What's going to happen to him? He's going to get into angina or myocardial infarction all of a sudden just because we are stupid and stop the drug all of a sudden. You got it? ماشي. ليش بتوقفي؟ إما المريض هو وقفه. تعال. Okay? Which is something you do not know. So you have to communicate with your patient exactly. أو something else إنه إجا واحد وتفز لك، لا والله أنت بنفع كاشف، لو خلينا غير لك يا واحد. Which is what happens in reality. Okay? بيجي بروح عند هذا، ما هي إحنا عندنا المرضى إيش كلياتهم shopping for doctors. بيجي بسمع مني مع لا والله ما عجبنيش حكي. الدواء حقه 25 بدي دواء حقه 50. And so on. So the physician should know these things. ماشي. I am done with today's lecture. Tomorrow we're gonna finish. Wait! يم على طول. بس دقيقة لأنه في طلاب سنة ثالثة بدهم يوزعوا لكم شهادات. مين عنده لاب